Thank you again for the invitation. So I will talk about imaging of pelvic exenteration, mainly on pelvic cancer and mainly on rectal and cervical cancer, which are the two cancer which mainly needs exenteration. So as a just intro, and the guidelines we propose recently came up because we had a difficulty to handle such cases. And in this example of rectal recurrence of a patient who was 2 years of prostatectomy, it was addressed for suspicion of fistula, and obviously, as you can see, it was not a fistula, it was a massive mucinous recurrence of rectal cancer. And in that case, I saw my resident and fellow struggling reporting the case. They didn't know with what to start, what to report. And I found with these extensive and massive cases, it's really difficult to propose the standardized template. And that's why we came up with the idea of proposing some practice guidelines about pelvic exenteration. And in this joint guidelines with which we grouped the SAR group, the ESGAR, the ESUR, and the surgical pelvic group, we really come up with recommendation about the MRI image acquisition, some compartment and anatomical based approach, and as well a template for structured reporting. So what is pelvic exenteration? And pelvic exenteration is an en bloc removal of more than one pelvic organ. It's usually performed for locally advanced or recurrent pelvic cancer, gynae or rectal cancer especially, and for gynae it's usually cervical cancer. And you have to know that the first one and the first pelvic exenteration was performed in 1947 in a patient who was follow-up for a cervical cancer post-radiation therapy. And she had a recurrence, and they performed pelvic exenteration, and it came out very well with a long survival. So just to summarize what's the type of pelvic exenteration. So you can have an anterior pelvic exenteration when you have the recurrence, which is confined in the anterior pelvic compartment. So the surgeon will remove the female or male reproductive organs, and then the bladder and the urethra. And as you can see here, what will be removed, and on the post-surgical sagittal CT, what is left is the rectal sigmoid and the anus. Then we have the posterior pelvic exenteration, when you have a posterior pelvic recurrence, either, for example, on the rectum or on the vagina or on the cervix. And in that case, what is removed is again the female or male reproductive organs, and then the rectum and the sigmoid, and usually the anal sphincter and the perineum, with the preservation of the bladder and the urethra. So as you can see here, what is left will be the bladder, which will be an ICC under the sagittal CT. And then you have the total pelvic exenteration, when you removed everything. And at the end, what is left on the CT, on post-surgical CT, you will have mostly only fat. And you are removing all the compartment from the anterior, central, and posterior compartments. So let's discuss about the different imaging modalities in this kind of exenteration. So first, with the CT is interesting to evaluate the vessels, the bone, and the distant metastasis. Then we have the PET-CT for lymph node and multifocal disease and distant mets. And then we have the MRI, and this is what we are going to discuss mainly. MRI will give you a roadmap of the local tumor extent and will guide the surgeon evaluate the potential for surgery. So first, what about the MRI protocol? I must say the MRI protocol is pretty simple. It's the same as the cervical or rectal protocol. We are doing the classical
high-resolution T2 plane, sagittal, axial, and coronal sequence. If it's a specific recurrence on the rectum or on the cervical or on the uterus, you may want to have axial oblique sequences. And then you had the diffusion weighted imaging sequence and the injection. What can be optional but interesting is a non-enhanced T1 sequence without FATSAT for the pelvic anatomy and the bone. And for the patient preparation, what we advocate is the use of antiperistaltic agents such as glucagon or Bustocan. It's still optional, but sometimes to remove the artifact linked to the hair, you can use bowel microenema to remove all the hair within the rectum. So that's really a simple protocol. Basically, it's can hold in like 20 to 30 minutes with the three-plane high-resolution T2, the diffusion, and the contrast enhancement. So nothing really, really specific. Then we talk about the role of MRI imaging. Basically, what you need to tell the surgeon is whether the patient is eligible for a pelvic exenteration and whether there is a presence of contraindication. And for contraindication, usually you are looking for pelvic muscle, nerves, and bone invasion, external iliac vessel involvement, and lymph node metastasis. So that's really summarize what you really need to tell the surgeons on your MRI. And this is why we really generate all those structured reports. Why it's so important? Because we are not anymore at the palliative state when you have a recurrence in the pelvic site. Really, before performing exenteration, the patient has a very poor survival, like less than 5%, but the survival can increase to more than 50% if an R0 resection is achieved. And this your role as a radiologist to guide the surgeon, to tell the surgeon whether there is a change of the patient eligibility for exenteration, what he needs to remove to achieve the R0 resection. And you can understand that there is really an important discussion between you and the surgeon at the tumor board. So what is important? The first is a timing, and this is really important. This was a very interesting case. A patient was scheduled for an amputation. He has some post-therapeutic changes after chemoradiation therapy, after rectal cancer. And then the surgeon was asking on the tumor board whether he needs like to do some sort of sparing surgery with just removed of unblock of the fibrotic change and the residual tumor, or more like exenteration surgery. But the problem is, and this is really important in terms of timing exenteration, is the MRI is 3 months old. So the first thing really is to be sure that your MRI is really, I would say, really recent. Because in this example, we redid the MRI, and as you can see, there was a huge fistula, and that completely changed the patient management. It is still eligible for surgery, but that changed really the roadmap of the surgery. So really, in those type of cancer, or those type of recurrence, the recurrence can grow really really fast, and you really need to have recent imaging. So we advocate that the imaging is no more old than 1 month. So that's the very first point. Then we look at the reporting template, and we divided this in 3 to 4 parts. First, the tumor description, then what is involved in terms of organ and structural involvement, and the additional findings. So let's talk first about this reporting template. So this is what we propose in the guidelines. And we first with the tumor description. So tumor description, we divided in 3 parts. The first is what is kind of type of recurrence. Is it local, like anastomotic, pelvic sidewall recurrence? Is it a lymph node? Is it peritoneal? Is it just the regrowth of the tumor? So that's the first part. Then you need to evaluate the size, at least in 3 dimensions, at least one, but optionally, and in 3 dimensions. And then we had the location. It's really important to give some sort of compartment model of the location of the lesion. So we divided the pelvic in 4 compartments: the anterior compartment, which mimic the anterior pelvic exenteration with the bladder, the prostate, and the uterus and the cervix and vagina. Then you have the central with the bowel, and then the posterior with the muscle and the bone, and the lateral as well with the lateral pelvic floor with the bone and the muscle. So with that, you can give the exact location to the surgeon. And one point really I would like to advocate is that image says more than 1,000 words. And for example, you can give a prose detailed localization, but if you don't point out with an arrow to the surgeon, it will be hard for him to pick up because they are not used to the MRI technique. And so what we advocate is really to put arrows or to highlight really the tumor because they can really see what's going on, where is the tumor, and the location of the surroundings. Then we move to really what is important in terms of exenteration, what is feasible, about what is involved. And I told you, like, we need to focus on what kind of organ is involved and what kind of structure is involved. And for that, we propose the Boneview algorithm, which was already published, and we really advocate to use it. So just to remember what's is into the Boneview algorithm. So you have the bones, the organs, the nerves, the vessel, the ureters, and then the extra tumor site. And it's really easy to memorize. And after that, you know what's going on and what is easy to remove or not. We know that the bone are a contraindication. Usually the central organs are absolutely not a contraindication. The nerves will be a contraindication. The external iliac vessels are a contraindication, and the ureter, the bladder are not a contraindication. But that's really important because it changed the management in terms of surgery if you have an ureter involvement as well. And then you need to tell what is the kind of involvement, whether there is a focal contact, broad-based contact, or frank invasion. So let's review this. We propose a table in the guidelines about what are the key recommendations about how to assess the structural involvement and the different type of possible involvement according to the structure involved. So first, let's talk about what is involved, what has a close margin, a focal contact. So again, I'm repeating myself, but usually bladder, rectum, gynae organs, side wall, and internal iliac vessel are absolutely not a contraindication for pelvic exenteration. So as some example here, you have this very large tumor. As you can see here, you have a preserved fat plane between the tumor and the left peripheral muscle. So that's is absolutely not a contraindication for resection. You have just an abutment of the bladder, an abutment of the rectum, so it's eligible for exenteration. Another case where you do see an abutment but no encasement of the external iliac vessel, so that's safe. And here you have an abutment but no muscle invasion. So again, this patient is eligible for exenteration. In contrast, if you have external iliac vessel invasion, the nerve invasion, and distant metastasis, that's going to be difficult to resect. Just some case here, you have a close really abutment of the sciatic nerve. This patient can't be eligible for exenteration. Here, a clear encasement of the external iliac vessel, seeing this, and that patient can't have an external iliac vessel resection. I said can't because usually for recurrence, the prognosis is very poor and they don't usually want to put a graft and do some very like vascular surgery in those cases. So that's why usually external iliac vessels are a contraindication. In some cases, like primary sarcoma, they may want to go very deep into the surgery and they may do this resection, but usually external iliac vessels are contraindication. So just as some more case to put you again in some visual evaluation here, you do see that there is just an abutment of the vessel, so that's not a contraindication. In this case, here you can see that there is clearly an encasement here, a clear abutment, and even an encasement of the nerve here, and here it's even like larger and a tumor completely going through the vessel. So this is both cases are contraindication of exenteration. Just again, what's close margin versus actual invasion here? Easy. So here there is really a close margin. Here this is actual invasion. So that's like pretty like here in simple. So if we move forwards to some cases to look at the different part of invasion and different structure involved. So for the bladder and ureter, so here we have the case, it was a cervical cancer initially. I had a poor response after chemoradiation therapy, so the patient got an exenteration. So it was non-anterior and pelvic exenteration with the removal of the bladder and the cervix. And as you can see here, we have a very nice neovagina flap here, which we did some gel, so to highlight it, there is some fat instead of the bladder. So this is a post-operative evaluation because the patient had a bladder extension. And unfortunately, the patient had a recurrence. So as you can see at the level of the vaginal flap here on the left side, there was a recurrence. And as you can see here, there is a close margin with the muscle here, but it seems to be safe and the patient was eligible for an exenteration. There was no bone invasion and there was no large muscle invasion, so the patient got another exenteration. Another case of bladder and ureter invasion here, you do see that there is a large tumor, cervical tumor invading the bladder. The patient was eligible for an exenteration for this infiltration. But if you go more into the image, you can see that there is an extension posteriorly within the rectum. So those patients would need a complete total pelvic exenteration, removing the bladder, the gynae organs, and the rectum. However, when we look more closely at the case, unfortunately, we found out that the patient has a bone metastasis, and that was a complete contraindication for exenteration. Another case, post-chemoradiation therapy in the patient for cervical cancer. You do see here there was some large fistula between the bladder and the vagina here, and the patient has a still residual disease surrounding both ureter here. And the patient, because it's the recurrence is still confined within the central compartment, and there is no extension with the bone, the vessels. The patient was eligible for an exenteration. So if we move to the vessels, I told you like the external iliac vessel are contraindication. The internal vessel are not a contraindication. They can do a ligature. So in this case, really clearly, there is a clear extension within the external iliac artery and vein. So that's not possible for exenteration. In this another case of it's a sad story because it was a 10 years after surgery for cervical cancer. Nodal recurrence with necrosis of a node completely centered on the external iliac artery, and the patient was not eligible for exenteration. So what about nerves involvement? So we are looking for the infiltration of the sciatic nerve or the lumbosacral plexus. And what are the signs? We are looking for hyperintense signal intensity on T2 and some enhancement of the perineural soft tissue on gadolinium. Usually what's help is looking at the other side, and you can see like here there is completely a difference between side, and in that case there was an infiltration of the sciatic nerves, and usually because of the high morbidity they can't perform an exenteration in those cases. If we finish with the bone and the muscle, well, it's usually it's easy to look at the bone invasion. You are looking at the loss of low signal intensity on T1 and T2 PATSAT image. And like in this case, as you can see here, there was a clear involvement of the bone. In contrast with this case, or where you see that the bone is completely intact, so the patient may be eligible for an exenteration. So we are reporting the tumor description, what is involved, and then we need to add some little addition, I would say, especially whether there is extrapelvic tumor site, the nodal invasion, whether there is anatomic variant, especially for the vessel. It will guide the surgeon into his management, whether there is post-treatment changes or complications, such as like bone fracture, especially after radiation therapy, and the response to neoadjuvant treatment, but that's less concerning about the exenteration. What is really important, I would say, is what is involved. So just as a case, in this case, patient was eligible for exenteration, but we found out that he had like lymph node metastasis, and we did a PET CT, and the nodes went really high up into the abdomen, so we decided not to include her in the part of exenteration pathway. So just to finish, I would like to highlight how we do with the reporting template with some cases. So as the first cases, it was a patient, 52 years old patient, status post bilateral salpingo-oophorectomy with an end colostomy, and she had a recurrence, as you can see here. We do see the recurrence here and here. So if you go for the template, I feel like it's really easy now to describe the tumor and to guide what is important for the surgery. So for the tumor description, we can say that this is a recurrence. The location is really central, and we can guide the size of the recurrence. And then we move to the organ and structured with tumoral involvement. So what I like to just use is the bone view algorithm and just go from there. So bone, it's really central. There is absolutely no bone, so we are safe. Then organs, okay, it's ending the end of the sigmoid, or what is left in the rectum, so it's here. And then we have the vaginal cuff involved. Nerves, there is no nerves involved. And what is important here is vessels. So the vessels, we can see that there is clearly a contact with the external vessel, but there is a less contact on less than 180 degrees. So this patient can be eligible for an exenteration in this case. We don't see any nodes on the rest of the MRI, and so the patient is eligible for an exenteration. And with that, you can discuss at the tumor board, and you have a very nice structured report. Another case, patient was has an history for abdominal perineal resection followed by because of the rectal cancer. And you can see here that there is a tumor recurrence. So if we start with the tumor description, it was a recurrent tumor. We can give the location of the recurrence, so it's a right pelvic sidewall, as you can see here. Then you give the size, and then we move to the organ and structure with tumor involvement. So again, with the bone view algorithm. So bone, doesn't seem to be invading the bone, but it's really close. But there is still a safe margin, I would say, of 1 or 2 millimeter between the obturator and the peripheries muscles. You can see here the tumor here, and then you have the muscle here, and then the muscle here. So it's really, there is still a clear safe margin. So in this case, this part is okay. Then we move to the O of Boneview for the organs. So we are looking at what is involved. So first, you can see here, there is a right seminal vesicle, which is involved. There is a frank invasion, and there is some contact, maybe focal invasion of the small bowel here. Then we move to the N with the nerves, and that really give you some structure. Again, I'm repeating myself just to not miss anything. And here we are looking at the nerve, where are the nerve and what can be involved. And in this case, there is a sacral nerve plexus here, and it's clearly a frank invasion at this point. There is no safe margin, and this is a potential contraindication. Then we move to the vessels. So if you look at the sagittal image here, we can see that there is a right internal iliac artery and vein encasement here. And finally, for the ureter and the bladder, there is a dilatation, there is an hydroureter, and there is a frank invasion. So at the end, from the just giving the size and the potential invasion, you came up with a really nice structured report about what is important. They don't care about the fat, they don't care about the aspect of the lesion, they really care about the surroundings, about the bone, the organs, the nerves, the vessel, and the ureter, which is involved. So that's really what will help the surgeons. So at the end, how you will communicate those image findings. So as I told you, you really need key image and the adequate description. We discussed this with a structured report, but the most important, I would say, is to discuss the image with the surgeon at the tumor board, because I felt like when you are describing, if sometimes on the MRI, it's not as easy as the CT, and it may really difficult for them to interpret correctly the image. So really showing them where is the recurrence and what is involved is really important. So in conclusion, really, I would say pelvic exenteration is really something part of another, like we are when we are reporting endometrial cancer, cervical cancer, it's not the same as when you are reporting pelvic exenteration, because usually for cervical, or for example the standard endometrial cancer, they perform the standard surgery and that's it. For pelvic exenteration, really you need to describe what is involved, and really what's your expertise will really help the surgeons in their management. So that's really important, and that's why we need to have this tumor board communication. So that, I think I'm done. I really would like to thank you again, for Mark Ducky for the invitation, and I really be happy to answer all the questions. And the article, which was not initially on open access, will be soon, so it will be available for download pretty shortly.